I'll just start talking and that's how. All right, hello everybody. Welcome to another session of dental shadowing. Today we have Doctor here to talk to us. She's going to talk to us a little bit about orthodontics, her story, and also managing having 2 kids during dental school as well as residency. So you can go ahead and take it away, Doctor.
Hey everybody, thanks for joining us today. I'm Dr. Poulos. I just graduated orthodontic residency, so I'm an orthodontist. I'll tell you a little bit about my story. We'll go through all of that info, how I came into the world of dentistry, applying to dental school, getting into ortho residency. It's kind of a different story, so we'll go over all of that. And then I've got just a few fun cases to show you guys some of the cases I treated during residency. So we'll have questions that you can ask freely at the end. I'm happy to answer any questions that you might have. So we'll go ahead and get started. So starting out my journey, I did not know that I wanted to go into dental school right away. I went to college at a small school in North Carolina. It's called Appalachian State University. And I started out as an art major. So my whole life, we'll talk a little bit more about it in a few slides, but I've always had a very creative background, enjoyed crafting and all sorts of art. So I started out as an art major, but then, kind of started to think realistically, what am I going to do with an art degree after I graduate college? And I didn't want to be a starving artist. So I decided to change career paths. And instead of majoring in art, I decided to double major in chemistry and biology. So I did that. And then kind of that's how I fell into the path of dentistry. And I wasn't quite getting in, which we'll talk more about too. It took me 5 years to get into dental school. And I'm happy to share those struggles and kind of what I did in those gap years in order to get into dental school. But I ended up doing this master's degree at North Carolina State University. It was mostly online. It was a master's of physiology degree, and I'm sure they have very similar programs all over now, especially because of COVID. So I really thought that that was something that helped propel me into getting accepted into dental school, probably one of the most important things as far as just looking good on paper and getting into dental school. I was accepted into the University of Maryland School of Dentistry. So I went there and graduated in 2018 up in Baltimore. And during my last year of dental school, applied to orthodontic residency programs, and I was accepted. You go through a match program, which if you guys are not familiar with the match program, it's similar to medical school, but you apply to multiple schools, and whatever interviews you get, you rank the places that you interviewed at, and then the places that interviewed candidates also rank the candidates, and there's a algorithm that matches you all up where it's supposed to, but there are people who don't match, and I was one who did not match, and I had to go through the post-match process, which was a little bit stressful, but I was able to secure a spot at Arizona School of Dentistry and Oral Health, which is where I received my master's in orthodontics and just graduated this past December. So we'll go into a little bit more details, but those are kind of the schools that I've attended. More importantly than just school my whole life, I do have 2 little boys. My youngest, I can't believe he just turned 1 on the 10th, and I don't know how that happened so fast, but so I have a 2-year-old and a 1-year-old right now. It's kind of crazy. My 2-year-old will turn 3 in April, so they're almost 2 years apart, but not quite. So my first Maddox I had during dental school, my last year of dental school, so I was busy taking board exams, clinical boards, and the ADEX, and it was definitely crazy, but manageable at the same time. I think as far as timing and when to have kids, you can never say it's a good time. You just do what you want to do. If you want to have a kid, you have a kid. And so that's what we did. And I think it's best, as a working mom, you're still going to have to rely on your income and have to work. As a dental student, you don't really have to worry about making the income because, there's student loans and all that kind of stuff. So it was almost easier in my mind to just have the children during dental school and residency than have to miss out on the income that I would be making if I were working. Or if you own your own practice, you really can't take a lot of time off. So it worked out for me. It was busy, yes, stressful, of course, but I think no matter when you do it, it's probably going to have some of the same feelings. So that was Maddox. And then my orthodontic residency baby, Hudson, he was born, like I said, a year ago. So that's us down in the bottom in ortho residency. We had a lot of us pregnant at once, actually. So all 4 of us in that picture are pregnant. There's the dental assistant and then 3 residents, my co-residents, we were all pregnant together. So it was really fun. It was a fun time. And then over on the right, that's little Maddox graduating from dental school. So it's busy, but doable for anyone who might be getting kind of a later start or just ready to have children and also wanting to pursue a career in dentistry or orthodontics. It is something that is definitely doable. So like I kind of alluded to, I have been crafty my whole life, which is why I started out as an art major in college. Kind of my biggest passion is making wire jewelry. So here's some of the pieces that I did. In dental school, actually, I did some like tooth related jewelry and kind of sold that to people because, we're all obsessed with teeth. But it's one of my biggest hobbies. I will say I haven't done a lot of it lately because I've been super busy with those 2 children and residency and graduating and all that stuff. But it is something that I do to relieve stress. And, having a hobby is definitely something too important. Of course, applying to dental school, but just as, self-care and health for yourself to have something that you do that you're passionate about aside from all the school. But it also will look good on your applications if you do have a hobby to kind of play that up, especially something that shows manual dexterity, working with wire jewelry, it does help to advance kind of your skills with working with your hands. And it was what drove me into dentistry because I have the science background, chemistry and biology, but then I knew that I wanted to do something with my hands, making things beautiful with my hands. And there's really no other career that you can use the science and make something beautiful using your hands every day. Medicine is maybe surgery, but that's not something that I wanted to do. So, but it was the perfect fit for me and for what, my passions and hobbies were. So that's why I ended up choosing dentistry. I didn't know right away in dental school that I wanted to do orthodontics, although it's kind of like in retrospect, I'm like, how did I not know? Like wire jewelry, bending wire for teeth, it's totally related. But I didn't first go into dental school knowing I wanted to specialize. I just knew that I wanted to have that option. So I worked hard to, keep good grades and stay active with different programs at my school, just because those are things that they look for when you're applying to orthodontic residency programs. So, yeah. So not only did I do that little master's program, but here are some other things that I did, which helped me during those 4 crazy years trying to get into dental school. I know if this isn't your first time applying, I know how much it sucks to get a rejection letter. I calculated how many schools I applied to and how many told me no, and it was 27. So I had 27 no's before I finally received my first yes. I hope that doesn't upset you or like make you feel like, oh my God, what am I doing? If it's something that you want, you will get it. You just have to keep trying. People, it got to a point where people were kind of like, so like, what's your backup plan? And I was like, I don't know. I don't have a backup plan. This is what I want to do. There's nothing else that I could see myself doing and being happy doing. So, if that's the case, it's just time, and money, just that time and money, just keep trying. And eventually you will get that yes. These are some of the things I did in addition. I was working as an office manager at a dental office, kind of lucked into that job after college. I worked at a practice just as like an assistant receptionist, and the manager ended up leaving and was like, well, you're the only other one here. Do you want to be the manager? And I was like, all right, sure. So I was kind of thrown into that job, had no idea what I was doing, but just kind of figured it out. And honestly, it was experience that I will never forget and has really shaped who I am as an orthodontist. When you've seen dentistry from both sides, I think it changes your perspective and like how you treat your assistants and your staff. It really shows you like full 360, how to work as a team together and what's needed from both ends, both on the dental side and the staff side. So that experience was irreplaceable in my mind. While I was working there, the dentist was really helpful and knew that I wanted to pursue dentistry, and he helped me get my radiology certificate, which you can easily get, just to certify you to take x-rays. And in North Carolina, I think laws are different in different states, but in North Carolina, you don't have to be certified to be a dental assistant, but if you're going to take x-rays, you have to be certified. So I was able to assist during procedures, take x-rays when needed. It helped him out because I was able to jump in when other people were busy. And it helped me out because it gave me more experience and looked good on my application. I did retake the DAT. I took the DAT a total of 3 times. After the first time, I took the Kaplan course, and that did help. So I would recommend, if you are struggling on the DAT, to take a course. I know there's other ones out there. I like the Kaplan course. It worked for me. I took it a 3rd time, but it really didn't boost my scores any. My DAT scores were average. They weren't stellar. They were just average. But it is what it is. Like I told you, I did the Master's of Physiology. Every time that I received a rejection from a school that I really liked, I would reach out to the directors, after I'd kind of calm down and like organize my thoughts, and ask them what was weak about my application, what I could improve upon. And one of them recommended this Master's of Physiology program. So that's kind of how I fell into it. And I was like, okay, well, I'll just do it. It's only time and money, like I said. So I did that. And I really think that was huge in getting me into dental school. My GPA from undergrad wasn't great. It was like 3, maybe like 3.0, 3.2, but not like stellar. So I think that was kind of, unfortunately, it is a numbers game. When your applications come in, they do sort everything first by numbers. So if you're not hitting those, those quotas, they're not even really going to see the rest of your application, unfortunately. So I did get a 4.0 in the master's program. So I think that kind of got me through the door. And that was huge in getting me into dental school. Another thing that I think was big about getting into University of Maryland is, in my hometown where I was working, we had a periodontist that we would refer to, and I helped her out and we became close. I actually worked in her office a little bit on the side too. She went to the University of Maryland and wrote me a letter of recommendation for my application. So if you can reach out to anybody, pull all the strings that you can to get you into these places. I think her having been a student at that school really held a lot of weight and was part of the reason too why I was accepted at the University of Maryland versus other programs. Shadowing, of course, I know things are different now with COVID, but honestly, this is way better because when I remember shadowing, I don't remember being able to see anything. I was just standing on my feet all day. It was hurting my back, it was hurting my feet, and I couldn't see what was going on. So this is actually way better because you can actually see up close photos, and you're not, you can do it from the comfort of your bed or your couch, and you don't have to have all that awkwardness. But volunteer work, obviously, we had Missions of Mercy and just really anything that you can get your hands in. I think when it comes to volunteer work, if you can find something and be consistent with it, it's probably better than jumping around and doing a bunch of random things, but a bunch of random things is better than nothing. So if you can find something that you really can invest your time in long term, I would recommend doing that. But however you end up doing it, it's probably fine. Again, the biggest thing that I think got me into dental school too is just not giving up. I could have easily given up 27 times, but it's just not something that I was willing to compromise. So, you know, you just keep trying to be better, never stop trying to improve. You know, I never submitted the same application twice, and you just keep plugging away. Post-match to residency was also very stressful. I think you'll learn more about this too if you don't already know, but in dental school, there's usually not many post-match spots. I think the year that I went through it, there was 2 or 3. And, you know, you've got probably hundreds of people that are trying to get them. It worked for me because I had actually interviewed at Arizona School of Dentistry and Oral Health for the orthodontic residency program. So they had already met me. They knew my face. They knew my application. And I think that's really why I was able to get that post-match spot rather than them giving it to a complete stranger. They're like, hey, we already know this girl. She qualified and we wanted to interview her. So I think that's really why I was able to get that post-match spot. It's not something that's very common. So what am I doing now? So like I said, I graduated from ortho residency in December. So I'm a newbie, and I got a job. I left the beautiful state of Arizona at the perfect time of the year where it's like highs in the 70s and sunny all the time and beautiful, and moved to Mississippi. And right now we have like 4 inches of snow outside, and it's like 14 degrees, which I did not think it would be that cold in Mississippi, but it is. And I know I shouldn't complain because Montana is like -20 or something right now, but coming from like Arizona to this, I'm freezing. So I'm in Mississippi now. A little town called Hernando is where we live, and I work in a little town called South Haven. It's basically Memphis. I'm 15 minutes from Memphis, Tennessee. So it's nice to have the city kind of close by and still be kind of this small town vibe that we have here. I don't think it's something that I'm going to stay here permanently because it's a little cold, but you know, for now it's working, and I'm going to be working in corporate for a few years. I signed a 3-year contract. I'm happy to answer any questions. I don't know exactly what stage you guys are at, but I'm happy to answer questions about that too. But I'll be working 4 days a week here in Mississippi for the next 3 years or so, and then who knows? I do ultimately want to own my own practice, but you know, that'll be down the road. I'll get a little bit of experience under my belt and kind of go from there. So getting into more orthodontic specific things and cases. So orthodontics is a specialty of dentistry that deals with the diagnosis, prevention, and correction of malpositioned teeth and jaws and misaligned bite patterns. It can also focus on modifying facial growth, known as dentofacial orthopedics. Abnormal alignment of the teeth and jaws is common. So we use all different sorts of modalities to correct these problems, including braces like you would think of. We have all different kinds of braces. So you can see in the little picture down below, there's different kind of mechanics to braces. There's what we call self-ligating braces, which have a little door that opens and closes and the wire slides in. There are twin brackets, which are basically stationary. There is no door. You put the wire inside, and then you put, you know, the famous color tie or metal tie around it to hold the wire into the bracket. Brackets would do absolutely nothing if there was not a wire that was being held in. So we have to have some way to secure the wire to the bracket. So it's either with a door or with an O-tie, the elastic O-tie or metal tie. We also have clear ceramic braces that we can use, which appeals to a lot of people because they're not quite as visible, you know, as the metal ones. And then as far as visibility, we also have braces that go on the inside of the teeth, on the tongue side, on the lingual side of the teeth, which some people prefer because you really can't, when they smile, you can't tell that they have braces at all. So there's all different kinds of fixed appliances in terms of braces. We also have all sorts of clear aligners, which I'm sure you've heard of. Invisalign, there's ClearCorrect, there's a ton of different clear aligners. People are actually starting to, on some cases, make their own in-house clear aligners, which I'll talk a little bit about too. I think that's probably, for simple cases, something that is more financially beneficial to the orthodontist and then therefore the patient. which I think we'll be seeing more of in the future with the advent of 3D printing technologies. Surgery in severe cases, sometimes the jaws are so far from each other that the only solution to get the teeth to come together is through orthognathic surgery. So we'll work with oral surgeons to coordinate care for patients who have skeletal discrepancies. We do exposures. So sometimes teeth don't erupt the way that they should erupt, and we have to go after them. And we can sometimes do them ourselves if it's, just under the gum tissue. We just need to expose the tooth a little bit and bring it in. Sometimes there's also bone that's covering the tooth, in which case we'll typically refer that to a periodontist or oral surgeon to coordinate care to get that tooth in that needs to come in. Gingivectomies is also something within our scope that we often do for patients who perhaps have either overgrowth of tissue, sometimes as a result of treatment and poor hygiene, but also sometimes just anatomically the size of the tooth is too short because the gum tissue is too long. So by removing that tissue, it gives them a more aesthetic appearance. So these are all things that we kind of do on a day-to-day basis. So getting into a few cases here. So these are all cases that I treated during my residency program. So this patient here, she was kind of right after, kind of towards the end of her growth spurt. A lot of the times when we are treating patients, we want to target kind of right in the growth spurt because we can take advantage of growth. And so this patient was kind of right towards the end, but in her case, that was good timing. So we started treatment. So looking at the top photo, this was her pre-treatment records. She had crowding in both arches, maxillary and mandibular arches, so crowded that her canines were not able to come into full occlusion. They weren't touching her lower teeth. She did have, I think, nicely shaped teeth, and the gum tissue was in an adequate space. Her smile line was adequate. So smile line is what we talk about, the position of the upper lip in relation to the upper incisors. So when some people smile, you might be able to see 2-3+ millimeters of gingiva. And so we would say that that's a high smile line. And in some people, when they smile, you might not be able to see any of their top teeth. And we would say that's a low smile line. So she has an adequate smile line. You can see most of her top teeth without excessive gingival display. So I quite like that and quite like the position of her maxillary incisors. So that's something that I wanted to maintain during her treatment while still relieving the crowding that she had. She had no crossbite, and her midline, so the middle of her top teeth and the middle of her bottom teeth, were pretty well on in the beginning, and I wanted to maintain that throughout treatment. And they were also matched up with the midline of her face. So we have the facial midline, we have dental midlines in the top and bottom arches, and ideally we would like for all of those to be coincident and line up. So those were some of the issues that we wanted to address for her. So we put her in traditional fixed appliances, the braces. We used the twin bracket system for her and kind of went through our wire sequence. She did use rubber bands for a little bit, which rubber bands in orthodontics helps to do a number of things. Sometimes it's settling the bite, sometimes it's shifting the jaws, but in her case, it helped us kind of settle everything down and help us get those canines down into occlusion. So the bottom photo, the middle photo is her progress. So when she had the treatment, in the middle of treatment, and then the bottom photo is her final record. So I think she was really happy with the result. She had a nice broad smile. It didn't seem to have changed the position of her maxillary incisors too much, and kept those midlines pretty well on. Just were able to relieve that crowding for her. Okay, we can look at the next case here. So this is a little more complicated of a case. In residency, the program that I was at, we have a kind of a deal with St. Vincent de Paul, who is a kind of a charity organization. And we would go down and into Phoenix and provide care for folks who probably wouldn't be able to afford orthodontic care if it weren't for this program. So, I mean, and it can be life-changing for some of these folks. So it's a really rewarding thing to be able to give back. In her case, you can see that she has bilateral posterior crossbite. So the top teeth are on the inside of the bottom teeth on both sides in the top. And as well as severe crowding. You can see those canines, especially the one on her left side, is not able to come down into occlusion. It's crowded out. Her midlines are pretty well on. She really doesn't have much of overbite. So when we talk about overjet and overbite, there's kind of two ways that we talk about teeth. So these are your top teeth, these are your bottom teeth. So overjet is this direction. So bucky teeth means they have too much overjet, and then overbite is this way. And so if there's too much overbite, then we call that a deep bite. And if there's like if the teeth don't touch in that direction, then it's an open bite. So in this case, she's very borderline. I would call her kind of edge to edge. She doesn't have a lot of overbite. And so that's something that we had to be really careful during treatment, because it's very hard to increase that in a case like this, especially when she needs some widening of the maxillary arch. So what we did with her, we started with an expander, which is a device that hooks onto your molars. It's an appliance that's permanently worn during treatment, and there's a little key that you can crank, and it slowly widens the top teeth. You have a suture on your maxilla, the mid-palatine suture, that doesn't fuse until after puberty. So that's why we also like to start treatment at certain times. So ideally, for someone who needs expansion, we want to start before puberty ends. Earlier the better, really. I mean, to an extent, obviously, but 7, 8 years old is a great time to expand. You can still get some expansion, 10, 11, 12, just kind of depending, but she needed expansion, so we went ahead and did that. And then we put her into just traditional full braces. I don't have a progress photo for her because it was down in the kind of the clinic where we serve others, and we don't really have a lot of equipment down there, so I don't have progress photos for her, but you can see her final photos. I was really happy with the way she turned out. Her smile is so much broader. That's from the expansion, and we were able to crack the crossbite, so she no longer has any crossbite. The midlines are a little bit off. Sometimes we have to compromise the way that the teeth fit in the back for the way that the midlines line up in the front, if that makes sense. So that's what we did in her case, but I was really happy with the way it turned out. I mean, she looks totally different, like a whole different person. So she was a sweet girl. We can look at the next case. So this is an adult patient, and she was treated using Invisalign. So a little bit different switch up here. She honestly, I wasn't quite ready to be done with her, but she was ready to be done. So the final photo, she was really happy with. I still see some things that I would want to correct if I could. I think you could say that about every case though, but so she came to us. She's never had braces before. She's an adult. She was a nurse, labor and delivery nurse. She did not want braces. She wanted Invisalign. And so with Invisalign, she needed something called interproximal reduction, which is where we kind of go in between the teeth with a little tiny strip. There's different ways to do it, but I use a little tiny strip. It's kind of like a nail file, and it's like nail file floss, and you kind of go in between the teeth, and you're reducing like hairs of millimeters of teeth, like 0.1, 0.2 millimeters. And if you do that over the course of several teeth, over the course of her entire treatment, then you're able to gain space to uncrowd the teeth. So as you can see in her initial photos, she does have a lot of crowding in both arches. Her midlines are off, and you can also see, especially on that right side, how her arch form is kind of sucked in the posterior segments and not full and broad. You can't see as much of the premolar and molar as you can of the canines and the first premolar. So what I like to put, as far as final treatment, I like you to be able to see each tooth in the arch when you're looking straight on all the way back to the molars, and it be relatively symmetric. And I think that we were able to achieve that for her. So if you look at the final photo, especially in the maxillary arch, you can see how much more of the tooth that you see in the posterior segments of the second premolars and first molars. They really have come out. And that's just through the aligners. She didn't have any sort of expansion done as far as an appliance is concerned. It was just through using the aligners. And another thing that I like to do, and we'll talk a little bit about, is reshaping the teeth. It's a procedure called enameloplasty. It's just kind of reshaping, recontouring the teeth, and that's something that we did with her too. And I think it really helped soften her smile in the end. But there are some things, like when I look at her, especially the lower arch, that I would have probably wanted to improve. I think her lower left canine is still a little bit protrusive. I would have liked to have tucked that in a little bit. And, I think there's still a little bit of an asymmetry. She started with an asymmetry, and it's certainly better, but I think we could have corrected that cant a little bit more. But she was very happy. So, sometimes you just have to go with the happy patient and go for it. So this is another little girl here. So she didn't like her diastema. And I know we talked a little bit about overbite. So this patient also had a deep bite. So when she bites down, you really don't see any of her lower teeth in the initial photos. And you can compare that to the final photos, where you can see basically almost all of her lower tooth. So this patient had a deep bite. She had a diastema. She didn't have any crossbites or crowding. She actually had a little bit of spacing. And we were able to correct that just through traditional braces for her. She was a great patient. We did her treatment, I think, in like 18 months. So relatively quick. Closed that diastema, opened the bite a little bit, and it was a relatively straightforward case. I did with her, when she started, she does have a little bit, I think, longer gingival tissue than what I would like to see. I would like to see a little bit taller of central incisors. And so we did do a gingivectomy on her after her braces were finished, and that increases the height of those crowns. You can go to the next slide. I'll have an up-close photo of the gingivectomy for you guys. This is another adult patient. This case was extremely difficult. So adult patient, she had deviated midline. Her maxillary midline was deviated about 2 millimeters to her left, severe crowding. It's hard to tell in the photo, but her central incisors are butterflied like this. Which we do see quite often. She has buccal crossbite. So this is a little bit different than the other crossbite that I showed you, where the top teeth were too far on the inside of the bottom teeth. In this photo, her very last molars, her second molars, are completely outside of her bottom teeth. So instead of her teeth fitting together like this, her top teeth were out here and totally missing each other. So we call that a buccal crossbite or a Brody bite. And so what happens over time is they keep hitting each other, and then they slip past each other, and then this tooth on the bottom kind of lingualizes and tips in towards the tongue, and the upper teeth flare outward. So that's something that we had to address for her. She has, you can't really tell in these photos, but we look a lot at the angle of the jaw, and that also has repercussions in terms of growth and treatment. And she was a very high angle. So if you think of your jaw, and you can imagine a line going from the plane of your jaw all the way out, if it kind of touches and is in the same line as the back of your head, that's normal. If it goes way up like this, and we would call that high angle. And then low angle, I would say I'm maybe a little bit low angle. Just that basically means your jaw is a little bit more straight this way. So high angle, normal, low angle. This patient was a very high angle, which is also something that's very hard to treat because you risk opening the bite for a lot of reasons. But so this was a very challenging case. We treated her with extractions. She had 4 bicuspids extracted for her treatment in order to fit everything together. Really, her lower arch wasn't that crowded. It was mostly because of the crowding in her upper arch that we elected to extract. The initial plan for her, because she did have excessive gingival display, she had kind of a gummy smile, was to use mini implants, tabs, to intrude her posterior teeth in order to help us correct the gumminess in her smile. But we had some hiccups along the treatment in terms of her oral hygiene and her needing some root canals and apicoectomies. Long story short, we did not end up really utilizing the mini screws in her treatment. So the extractions were performed. This is another case, and I'll show this up close to you as well, where the reshaping of the teeth, enameloplasty, really came into play. Another pointer is when, especially in adults, but kids too, but especially in adults, when they're super crowded like this, there is no room for the gum tissue to grow down and form a nice, pretty papilla. So when you uncrowd the teeth, hello, there's a black triangle. And you can see in the progress photo, she has this huge black triangle right in front of her big teeth. And nobody likes that. You might not notice it, but if you're the patient, you definitely notice it and hate it. So some ways that we can solve that without doing anything to the gum tissue is by doing some of that interproximal reduction in between the front teeth, which allows the teeth to come together a little bit closer, so you don't notice the black triangle as much. Also, by tipping the teeth in just a little bit, it helps us to eliminate that black triangle too. So we can head to the next slide, but I think her finish, considering the severity, turned out pretty good. If you notice the discoloration on one of her teeth, she had a trauma. That upper right incisor is a little bit off colored. She had trauma, and so that's part of it. My little boy is crying. I don't know what's happening. So this is my surgical patient. So sometimes the jaws do not fit together at all. And in this patient's case, it was because of her jaw joint. So she had arthritis in her jaw joint. And so what happened was her condyle, her mandibular condyle, was essentially missing. It had eroded away because of the arthritis, resulting in the skeletal open bite that you see, as well as the cant that's present. So we treated her with orthodontic surgery. We just did a maxillary surgery, and we were able to move the upper jaw and then allow the lower jaw to meet up with the upper jaw. And I think it turned out fabulously. She has ended up being like she lived in my neighborhood. I didn't know it until we were like walking down the street. I was like, wait a second. And we ended up being close friends, and she has 2 young kids about my kids' ages, and they played together. And so yeah, she ended up being a good friend, but we were able to really change her life. I mean, she can eat an apple now. When you do orthodontic surgery, you're changing these people's like lives, because functionally speaking, she couldn't function. She couldn't eat corn on the cob or eat an apple, and now she's able to do that. Not to mention, when she started, because of the arthritis, she was in severe pain, which at the end of treatment, she had no more pain. So we always treat the pain first. So she did go through a round of treatment with a TMJ specialist before we started any orthodontic treatment for her, but everything is going good now for her. So look at the next case. This is another relatively simple case. She did show crowding and kind of a deep curve of speed that we were able to level out just using traditional braces. The reason I show her is not so much because it's a difficult case, but because I think that throughout her treatment, she came to me, she like never spoke a word. She was so shy. And by the end of treatment, I mean, you can just see how she's like lighting up with this smile. She's totally come out of her shell. And it's really fun to be able to watch your patients transform like that, which is one of the reasons why I love ortho so much. You kind of catch kids in that kind of puberty growth spurt, and sometimes you really can you're seeing these patients like once a week. You can really have an effect on their self-esteem and their self-confidence. Kids can be so mean these days, and you really can make a difference in their lives. when you see them and are able to provide them with more self-confidence. So this was a case that's why I'm showing this one, not so much because it's complicated, but because it was a case that she really transformed, not just her smile, but her personality. So this is the gingivectomy procedure up close. So when I do it, you can do it with a scalpel. I use a diode laser. You could also use a CO2 laser, but I use a diode laser to resect the tissue. So you can see in the top photo, that's the before, how the length of the crowns on her upper incisors are all pretty much the same. So an ideal aesthetic situation, the central incisors are taller, and then the lateral incisors are a little shorter, and then the canines are about the same height as the central incisors. So you have this kind of high-low-high scheme going on, and she didn't have that to begin with, so that's what we wanted to give her. It's relatively straightforward. We do it under local anesthesia, and procedure takes maybe 30 minutes or so. So it's pretty quick. Healing is pretty much, I tell them it feels like a pizza burn. If you ever been into hot pizza and burn the roof of your mouth, that's pretty much what it's going to feel like. They look pretty gnarly in the beginning, but after a week, she's totally healed. So you can see the bottom photo is her healed after 1 or 2 weeks. And it's a big improvement from that top photo, especially if I wish I'd shown the smile photo, but it really makes a difference when you smile too. You notice it a lot more. I think it just makes her look much more grown up and mature. All right, we can go to the next one. So this is an exposure of a canine that we did. So this patient was really crowded and there was no room for a canine and it wasn't coming down on its own. So I used the laser again to resect the soft tissue and bond a little button to the tooth. And then I used elastic string to pull the tooth down slowly over time. And so you can see we were able to get that tooth in. Hygiene is not great, but you know, deal with that a lot. But we were able to get that tooth in and finish her treatment up. So this is kind of an interesting case. So if you start in the top right, like you read a book and go across and then across on the bottom, that's the progress of these. So this patient's lateral incisor was basically in the position where her canine should be and vice versa. So the canine and the lateral incisor were what we called transpose. They were basically switched positions. So we kind of had to do this roundhouse effect with these kind of crazy mechanics to spin that lateral incisor around, swing it away from the canine, and bring it into the arch while not messing up the canine. So in the final photo, the canine's not quite in, but it's almost in. It's in now, but it was just kind of something fun that I did in residency that I think would be kind of scary, but I was in residency, so we're like, let's just try it and see what happens, and I was impressed that it actually worked. So kind of a fun little thing there. Transposition is not something that's very common. So I touched a little bit about 3D printing. That's what I focused my research on. There's lots of applications that 3D printing can be utilized for in dentistry and in orthodontics. Instead of taking those goopy alginate impressions, we can 3D scan your teeth and then 3D print the models, and we can make all sorts of appliances off of that. We can 3D print brackets that are customized to your teeth to fit perfectly. We can use the models that we printed to stage different tooth movements and make aligners that will move your teeth. We can make your retainers, and then so if you lose a retainer, you can just call up and say, hey, I lost my retainer, we'll print you a new one. You can come in and get it. Splints are something that we use, like for the patient who had the TMJ problems. We can print those. There's unlimited things that you could do with 3D printing, and so just something to keep in mind, that the future is definitely digital when it comes to dentistry and orthodontics. No surprise here. My biggest piece of advice is just never give up. If that's what you want to do, then just don't ever stop until you're there. So I'm happy to entertain any questions. Thank you guys. You can follow me on Instagram or email me with any questions that you might have come up with that you might not feel comfortable asking, but I'm happy to help. So please reach out. if you do have anything that you don't get answered today. But I'm open to any questions. You can ask me anything dental, ortho-wise, mom, pregnancy, application stuff, job market, anything. So feel free.
All right, we have some questions in the chat for you. So someone asked, hi, what does it take for you and your team to work together successfully, thus being in a new office with new people?
It's just teamwork. Like with anything, you have to be delicate. They're especially going into a new place. You don't know how much somebody else knows, and they don't know how much you know. So open communication. For me, something that I learned is, if the office has been there for longer than I have been there. So rely on your team. Don't be afraid to ask questions. Let them guide you. It will give them confidence. It will teach them things, and it will teach you things too. So never underestimate your staff. And that was something that I learned too in residency. The assistants in the residency program have been there for like 8 years, and I have never put a bracket on a tooth before in my life. And so they're going to know how to do it better than I would in the beginning. So you have to respect that knowledge and look to them a lot for advice. And I think that when it's a mutual kind of teamwork, then there's a mutual respect there.
And then someone asks, hello, can you talk more about what you did during your 5-year gap?
Sure. So just to kind of summarize what I did during the 5-year gap, I was working as an office manager. I did the online master's program. I was volunteering. I was shadowing. I was reaching out to orthodontists in my community, periodontists in my community, trying to make connections, spending time with them, hoping that they're going to write me a letter of recommendation to school. Every time I would not get accepted, I would reach out to the schools and ask what I needed to improve upon. I took the Kaplan course, I retook the DAT, and eventually got into dental school.
And then someone asked, how hard was dental school, as well as which one was harder, dental school or residency?
I think dental school was harder. Dental school, it's like, what's the analogy? It's like trying to drink from a fire hose. They cram so much information down your throats all at once that you're expected to just memorize. It's just like pure memorization for at least the first couple years. And it gets old. I mean, when you have test after test after test, it's just hard. Residency, you have it's not like that. It's seeing patients, treating patients. Yes, you have classes, but it's what you want to do, and it's not like drinking from a fire hose. It's like, a more regular paced learning environment. So I would say dental school is probably harder.
And then someone asked about, they know that you're a mom and you did have your kids dental school residency. What would you say to somebody who is scared to pursue a career like this because they're feeling like they're going to get backtrack in life?
Yeah, I mean, I would say, you only have one life to live, and I think you should live it however you want to live it. If you want to have kids, have kids. If you want to be a dentist or an orthodontist, then do it. If it's happens to overlap time-wise, who cares? You only have one life. So it is scary, and I get that, but it's going to be scary either way. It's scary to go to dental school. It's scary to go to ortho residency. It's scary to have kids, and it's scary to do it all together, but like it's not that much scarier than if you did it separately. So just go for it.
And then someone asked about how your application changed as you kept reapplying. Like, what types of things did you change from your beginning application?
Sure. So, I mean, every time that I would reapply, I would have something else to add, whether it be a new DAT score, new volunteer work, a new, like the radiology certificate that I got. That was always something added new every year. I would change the personal statements around a little bit, but kind of go off of the same basis. Because I mean, it's hard enough to write one personal statement, let alone 5. But I did change it up a little bit each year. So I was always adding something. Whatever I did in the year between my applications, that was what was new on the new applications. And I was always trying to figure out something new to do, something else to add, whether it was, the radiology certificate or the master's degree, something.
And then I know you talked about how you're on a 3-year contract. What are kind of like the pros and cons of that?
Well, I mean, the pros are I know I'm going to have a stable income for the next 3 years and nothing's going to change that. The cons are if I don't like it, I mean, you can always get out of the contract. It's fine. But if you don't like it, you do kind of feel like you're stuck. But the pros too is that, you've got some guidance. You can seek others help versus starting out on your own. You're not all alone. It gives you a little bit of time to experience, practicing in a faster pace than what residency offers, and just more learning opportunities before you're quite ready to take that plunge into doing it all on your own.
And then our final question for you is, what is your favorite procedure?
My favorite procedure. I actually really like the gingivectomy and enameloplasty because everything that we do in orthodontics, it takes a long time. But when you reshape the teeth or reshape the gums, it's instantaneous. So you really see it right away. So I think I like that a lot.
All right. Awesome. Thank you so much, Doctor, for coming and talking to us today. We really appreciate it. Everybody, the post-session quiz will be in our Instagram bio after the session is uploaded. Thank you so much, Doctor, again.
Thank you, everybody.